Hi class, welcome to Unit 2 where we're going to discuss the GI system with further discussion on specific disease processes. We're going to start off by talking about patients that have gastric or duodenal disorders, and remember that duodenum is the first part of the small intestine. So let's start off by talking about gastritis. Gastritis is inflammation of the stomach lining. It could be related to an erosion problem or an atrophy problem. You can have it acute or chronically. The treatments are similar. The signs and symptoms are going to be nausea, vomiting, epigastric discomfort and pain. They may have hematemesis, melena. With acute, you're going to see more abdominal discomfort, headache, nausea, vomiting, hiccuping. With chronic, you're going to have epigastric discomfort, anorexia, heartburn after eating. They may be belching a lot, may complain of a sour taste in their mouth, intolerance of some foods, and with chronic gastritis, they may have vitamin deficiency due to malabsorption of B12 vitamins. When I say that gastritis is inflammation of the stomach lining related to erosion, many different things can cause that stomach line to be irritated and eroded. Illness, prolonged stress, medications like NSAIDs or corticosteroids are notorious for causing this problem. If there's an atrophy issue, many times that could be due to a stomach surgery, like a stomach resection. It could be related to pernicious anemia or even H. pylori infection. The test that we typically run with gastritis is we check an H&H, hemoglobin hematocrit, for anemia. We will do an occult stool test to look for hidden blood. We will do an H. pylori blood draw to see if they have that infection. And then lastly, if treatment isn't working or if their symptoms are too vague, we can go down and do a scope. So an endoscopy to look in the stomach itself. Diagnostic is usually by some sort of x-ray or endoscopy. Some doctors will treat it empirically, which means based on symptoms alone. The treatments that are common for gastritis are antacids, but remember that when we give antacids, we need to assess renal function to make sure that they can get rid of the excess magnesium safely through the kidneys. Another medication that's commonly prescribed for gastritis is sucralfate, which is SUCARAFATE, and it's a unique medication. It's kind of a standalone in its drug class, and what it does is it kind of slowly dissolves and then it covers and protects the stomach, giving it time to heal. Some additional medications are histamine 2 blockers like Zantac, proton pump inhibitors like omeprazole, and if they do test positive for H. pylori, they will prescribe an antibiotic plus those other medications. If it is non-responsive to meds, or if their symptoms are worsening, think we're going to probably scope this patient. We just got to go in and look and see what's going on. We should do some patient education. They should avoid alcohol, caffeine, acidic foods, carbonated foods, NSAIDs, smoking. We should help them take steps to reduce anxiety, make sure that they have adequate intake of nutrients, and relief of pain. For acute, usually the big things is to refrain from alcohol and acidic foods and beverages, so like tomato juice, orange juice. I wouldn't have them be drinking that until their symptoms subside. Let's see. The thing with acute and chronic gastritis is it can progress to where they actually develop an ulcer, which we will talk about on a future slide. The other thing is with gastritis is the pain. By using, we don't prescribe pain medications, but by prescribing the Carafate, the Sucarafate, the proton pump inhibitors, that will decrease their pain, but it may take a few days for them to feel that relief. This next slide is just a picture to show when I say erosive gastritis, what are we talking about? So there's those cells that secrete the hydrochloric acid, and those are eroded away, and it's painful. And it can progress, or people can develop standalone peptic ulcers. So a peptic ulcer can be in the stomach. It could be in the duodenum. Those are probably the most common places for peptic ulcers to be found. 20% of the time it's in the stomach, 80% of the time it's in the duodenum. It can develop bleeding or perforation. Both those are more acute situations that we need to manage more aggressively. Perforation, they're going to have immediate surgery. Like I said with gastritis, common causes are stress, smoking, excessive alcohol intake, any sort of hyperacidity disorder where they're producing more stomach acid, and NSAIDs and corticosteroids. The symptoms associated with peptic ulcers are a dull, gnawing, epigastric pain, and weirdly enough, it happens often at night when the stomach is empty. For some reason, that makes the pain worse. If it's a duodenum ulcer, it's associated with a little bit of weight gain. You can also have intermittent nausea, occasional vomiting, hematemesis, or melena. What we do to treat it is we're going to have them be going to get IV fluids, probably going to put them on MPO, maybe put an NG down them to rest that GI tract, and then we're going to turn to our favorite gastrointestinal meds, our proton pump inhibitors, histamine 2 blockers, if necessary an antibiotic. We'll use a barrier med like Sucarafate, and then we're going to do some monitoring. We're going to do hemodynamic monitoring, serial hemoglobins, assess for the possible need for a blood transfusion, and if resistant to treatment, we may consider a partial stomach dissection or gastrectomy. The education that we need to provide to the patients with peptic ulcers is they need to eat a bland diet. They need to take the medications as needed, or as instructed. Stress reduction, stop smoking, stop drinking, avoid aspirin, NSAIDs, that sort of thing. The big complication with a peptic ulcer is they can start bleeding or hemorrhaging, and it can perforate, which both of those are medical emergencies. Perforation, it has a sudden sharp pain. They can have a tender, rigid abdomen. They could be in the fetal position because that can help decrease the pain. They are at risk for hypovolemic shock. They are at risk for peritonitis, progressing to sepsis, progressing to shock, and death. So this requires emergency surgery if they do have a perforation. I do want to say that a very common cause of peptic ulcers is an H. pylori infection, and they say upwards to 50% of the general population is colonized, but doesn't doesn't mean they necessarily have symptoms or it's a problem. And the big thing with H. pylori, they're going to be prescribed an antibiotic, and they have to make sure they take their full course to completely eradicate the bacteria. And then patients that are in the hospital are at an increased risk for peptic ulcer because hospitalization is very stressful. And when the body responds to stress, it includes producing excessive gastric acid, which can cause a peptic ulcer. So a lot of times hospitalized patients will be on a proton pump inhibitor or a histamine 2 blocker prophylactically to prevent ulcer formation due to their acute illness. All right, nursing progress or nursing process. How are we going to take care of these patients? We want to reduce anxiety, make sure they're getting adequate nutritional requirements, teach them about their medication plan, prevent ulcer reoccurrence, and prevent complications. So if we're worried about it progressing to bleeding or hemorrhage, we're going to assess for signs and symptoms of bleeding, hematoemesis, melena, anemia. Treatment is going to be IV fluids, NG tube if they're bleeding. We may go in and lavage the stomach. Usually anymore that's done with an endoscopy because they can go in and cauterize the bleeding spots at the same time as they're lavaging. And we're going to assess these patients very closely for shock and hypovolemia. So frequent vital signs, watching for subtle changes in their vital signs. We don't wait for the blood pressure to drop out. We watch to see, is it slowly trending lower and lower? That's a red flag. Is the pulse slowly going higher and higher? That's a red flag. We're going to monitor urine output because if they're bleeding, that's going to affect their circulating blood volume and adequate perfusion. So the longer that goes on, they're going to have decreased blood flow to the kidneys because it's not an essential organ, and you're going to see a decrease in urine output. So like I said, if they start having signs and symptoms that maybe they are bleeding or their symptoms are getting worse, we will scope them and, if necessary, do a surgical intervention. Let's see, let me just check my notes to see. Just to touch base on perforation again. Signs and symptoms include severe upper abdominal pain, and it can be referred to the shoulder. They could vomit. They could have a tender, bored, or rigid-like abdomen and symptoms of shock or impending shock. And remember, these people need emergency surgery. So we don't wait. We report these problems to the healthcare provider ASAP. Okay, so then let's talk gastric cancer. So it's less frequent than it has been historically, but it's still common. There's an increased incidence in men, Native American, Hispanics, African Americans. There are some risk factors, which are listed on the slide. There's some manifestations. And because the manifestations are kind of vague, they're really very similar to gastritis or peptic ulcer. Diagnosis of the disease is often made late. The treatment is surgical removal of the tumor, if possible. If it's too large, they can't resect it, or if it's metastasized, palliative care is the treatment. So if your patient has gastric cancer, we're going to just make them comfortable. And if they are going to have surgery, of course, patient education. We're going to treat their pain. This is the time where we would treat with pain medications. We would use analgesics if prescribed, and then we would also turn to non-pharmacological pain relief measures. We would offer psychosocial support So what are their fears? What are their concerns? Encourage patient and family participation in their plan of care, and then referral to other support people as needed. For example, social workers. With any type of a stomach problem, we want to make sure that we're giving them adequate nutrition and we're supporting optimal nutrition. And these are the steps that will help meet those goals. So these are the nursing interventions that would be appropriate for a patient that has a stomach problem. So I'm going to let you read those yourself. Let me know if you have any questions. What do we need to assess? If, like, for any of these conditions, what if we need to take them to the OR? So this is what you need to assess prior to the OR and after the OR. You'll see what I would like you to focus in on is what is specific to the GI system, and that's your abdominal assessment, and then what are the things that could go wrong. Identifying those potential risks early, taking steps to prevent them from occurring. Let's see. Some specific nursing interventions and goals are listed on this page. We're going to provide interventions to reduce anxiety, reduce pain. We're going to have them in the follower's position. We're going to do what we can to prevent DVTs. We're going to, they're probably going to come back from the OR with an NG tube, so we need to monitor that closely for output. A little bit of blood in an NG after a fresh OR is not uncommon, but by 24 to 48 hours after, that should resolve. So if you're looking at an NG canister and the blood was getting littler and littler and then it's all of a sudden getting worse, that's a red flag that it's not healing and progressing as normally. The other thing that we look at with NGs is as they're getting better, the output should be smaller and smaller because we're resting that GI tract. So taking a look at your total volume of output through an NG is important as well. So we've got complications. What do we do? What are those specific interventions that we can do? Well, if they're at risk for gastric retention, we may have to put that NG tube back down. If they are doing okay postoperatively, the doctor wants to discontinue the NG, we have to watch for gastric retention. Maybe the stomach isn't functioning as well as we think it is, and it's slowly retaining gastric secretions. We may have to put that back down again. Bile reflux, we could give them cholestyramine to help bind to that bile. We can do some nutritional supplements. Dumping syndrome, there are things that we can do to minimize dumping syndrome. Put them in the low Fowler's, small meals, lie down after eating. Basically, with dumping syndrome, what happens is the food passes into the small intestines and the large intestine very quickly, and that causes vasomotor and GI symptoms like diarrhea. They may feel sweaty, like their pulse is racing, like they're going to pass out. Other things that we can do is avoid high carbohydrate and high sugar intake foods and avoid drinking with your meals. If they do have fatty stools, steatorrhea, reduce their fat intake, and loperamide can help with that. This is dietary self-management. So these are things that people can do to manage those symptoms or those potential side effects post-surgically. Okay, so from the stomach and the duodenum, we're going to move down and talk about the intestinal and rectal areas. All right, first up is constipation. Super, super common, usually can be treated at home. There are normal variations of bowel patterns from person to person, and this is when getting a good patient history is very important. Not ask them just when their last bowel movement is, but how many bowel movements do they usually have in a day? What does the bowel seem like? Are they small? Are they dry? Are they hard? Are they loose? What's their dietary fiber fluid intake? When they feel like they have to have a bowel movement, do they act on it or do they sit and wait? Do they use any laxatives? Are they dependent on laxatives to have a bowel movement? And a bowel movement is fewer than 3 bowel movements per week, or bowel movements that are hard, dry, small, or difficult to pass. Patients can have something called perceived constipation. That's a subjective problem in which the person's elimination pattern is not what they feel it should be. And so sometimes we have to do an assessment and then offer education. And that will help them adjust their expectations to what is quote, quote, normal. Complications. So we really don't think about complications with constipation. We think of it more as a nuisance, but these are things that could go wrong. One thing is, I'll talk about this again when we get to the cardiac unit, but straining to have a bowel movement has repercussions. You can have a vasovagal response, a slowing of the heart rate, and that's going to decrease your cardiac output. And that's why, like after a major surgery, like including open heart surgery, they will prescribe a stool softener to make the stool soft and easy to pass and to avoid that straining and avoid the decrease in cardiac output. This is also why some people pass out on the toilet because they're straining so hard. Fortunately, it doesn't happen very often, but if you have a patient that has a low heart rate, like let's say their pulse is only 50, I would tell these people not to strain when they're trying to have a bowel movement either, because their heart rate is already low. It could make it go even lower, and then they are at risk for passing out. Other things that can happen, they can develop hemorrhoids from the extreme pressure they're putting on the blood vessels in the rectum. They could have a fecal impaction, so a clump that's not passable without help. They could develop anal fissures. Those are very painful. Hemorrhoids are very painful. Rectal prolapse, where the rectum actually pushes outside and then you have to push it back in. And then megacolon. And I have to say, megacolon is not mega common. So I'm not going to spend much time talking about that. So now you could have the flip side. You could have diarrhea. Diarrhea, we need to recognize the need for medical treatment. Diarrhea isn't just an inconvenience. It can be acute, it can be persistent, it can be chronic. So it's basically increased bowel frequency, more than 3 per day, with an altered consistency. So increased liquidity of stool. They're not soft and formed. They're mushy and runny. A lot of different things can cause this. We need to treat the underlying problem ideally. What we recommend for all these patients is rest, diet and increased fluid intake, avoid irritating food, including caffeine, carbonated beverages, very, very hot or cold foods, good perianal skin care. Because they're wiping a lot, they might even have oozing out of the rectum. That having contact with skin puts them at an increased risk for skin breakdown. We're going to give them medications to slow down their peristalsis if it's not due to an infectious problem. They may need to avoid milk, fat, whole grains, fresh fruit, and vegetables until this resolves. They may be lactose intolerant. Maybe they need to cut out dairy on a permanent basis. What could go wrong? Well, the big thing is fluid and electrolyte imbalances, dehydration. That can cause cardiac dysrhythmias. And then lastly, on the prioritization is skin care. So our big concern is we're losing fluid, we're losing electrolytes, they're going to become dehydrated, and we need to fix those problems to prevent the cardiac dysrhythmias. You can also have fecal incontinence, which has a variety of different potential causes, which you can read about on this. The signs and symptoms of fecal incontinence is minor soiling, occasional urgency, loss of control, complete incontinence. How do we diagnose this? We do a good history to determine the etiology. They do a rectal examination. They may do an endoscopic examination or radiography, x-ray studies. They could do a barium enema, a CT, and for treatment, what we usually do is a bowel training program, skincare, and emotional support. Specific diagnosis that seems to be more common lately is irritable bowel syndrome. It's a chronic condition that has abdominal pain with disordered bowel movements. So some people may have periods of constipation alternated with diarrhea. Some people have just diarrhea. Some people have just constipation. This is a little bit more common in women than men, and it has some known triggers. The signs and symptoms are going to be abdominal distension, bloating, pain, and alterations in bowel movements. You can have malabsorption disorders in the intestines. The hallmark finding for this is diarrhea or frequent loose, bulky, foul-smelling stools that have a high fat content and are often grayish. The symptoms are similar to irritable bowel. So the good thing is we don't need to diagnose. We just need to identify the problem, do a good assessment, and notify the healthcare provider. This problem is typically manifested by weight loss and vitamin and mineral deficiencies as well, which is not a characteristic of irritable bowel syndrome. Then there is celiac disease. Celiac disease is an autoimmune disorder to gluten. And gluten is found in wheat products and a lot of foods. Women are more likely to be afflicted than men. It has a strong association with people that have type 1 diabetes, Down syndrome, or Turner syndrome. And Turner syndrome is a growth hormone deficiency plus a lot of other things going on. But there is a link. So we know it's a genetic issue. It's an autoimmune issue. It's very real. A lot of people, I think it's almost become a fad lately to avoid gluten, but only those that truly have been diagnosed with celiac disease have been identified as an actual gluten allergy. Signs and symptoms: diarrhea, fatty stools, abdominal pain, abdominal distension, flatulence, weight loss, and celiac disease is a chronic, non-curable, lifelong problem. There's no medications to treat it. They just have to avoid exposure to any gluten in all foods and beverages. And it's ideal if they can consult with a dietitian to make sure that they're getting their nutritional needs met. Appendicitis. So, appendicitis is an acute inflammation of the appendix, usually related to an infection after blockage of the appendix. It's one of the most common causes for acute abdomen and the most common reason for emergency abdominal surgery. It's most common in young adults. Initial reports of like a crampy pain in the epigastric or periumbilical areas. Then it progresses to the classic right lower quadrant pain. This is the most common cause of right lower quadrant pain. Then following that they become nauseated and vomiting. Patients, when you do your abdominal assessment, may complain of rebound pain. That is pain after the release of pressure on the abdomen with an assessment. There is a particular point called McBurney's point. That is the classic symptom of appendicitis, and there's a picture of this slide. The most common treatment is surgery to remove the appendix. Our treatment goals for a patient with appendicitis is relieving their pain, preventing a fluid deficit, reducing anxiety, preventing and treating surgical site infections. We also want to prevent atelectasis. Atelectasis occurs when there's a person not taking deep breaths. So they've got a painful abdomen, maybe they just had surgery in their abdomen. It hurts to breathe deeply because with every move of the diaphragm, it increases the pressure in the abdomen where there's inflammation. And so they're not going to be taking deep breaths. So this is when post-surgically, we will encourage them to cough and deep breathe. We will encourage them to hold a pillow to their abdomen and brace themselves. That will help with the pain. And the whole reason why we had them cough and deep breathe and use incentive spirometer is to avoid atelectasis. Atelectasis is a precursor to pneumonia. Basically, it means fluid is accumulating in the alveoli sacs, which we know when fluids accumulate, then there's a potential or increased potential risk for infection to develop. And then we're also going to maintain skin integrity and maintain optimal nutrition. Just a reminder, we only use light palpation after auscultation when assessing an abdomen. And that's when you can get that rebound tenderness. All right, moving ahead, diverticular disease. These are abnormal outpouchings or little herniations in the wall of the intestines, and those are called diverticula. They can occur anywhere in the small or large intestine, but are found most often in the sigmoid. Diverticulitis is the inflammation of a diverticulum, and that happens when undigested food or bacteria become trapped in those little pouches. Let's see. Diverticular disease increases with age, and it is strongly associated with people eating a low fiber diet. And I think they're finding that younger and younger people are having this problem because the diets in the US are so poor in quality. Usually patients present with symptoms of GI pain, diarrhea, and then usually we'll do a scope, a colonoscopy. So instead of going down the mouth, we'll go up the rectum to look at the colon. What we do for these patients, and we encourage good fluid intake, ideally around 2 liters per day unless it's contraindicated due to another condition like heart failure. We want these people to eat soft foods with increased fiber content, such as cooked vegetables. We want to promote exercise, a good exercise program, and we can use bulk laxatives like Metamucil and stool softeners to bulk up that stool and decrease the risk of little stuff getting caught and trapped in those diverticuli. Let's see. So I said that constipation can do a fecal impaction. It could also lead to an intestinal obstruction, but there can be mechanical obstructions, like something physical is blocking it. It can be functional or a paralytic, so the muscle isn't working right. Those are anything that inhibits the progression of the bowel from moving forward. What do we do? Well, these patients are going to have an NG tube. So we're going to be managing that NG tube. So that means making sure it's placed in the right spot. And the gold standard for NG placement is pH paper, and it should be about 4 or less on the pH paper. If your pH paper is not definitive, like you can't tell what the pH is, or you're worried it's the wrong pH, the gold standard is to get an x-ray. We also are tasked with monitoring tissue integrity of the nair that has the tube and the oral mucosa integrity, because these patients are going to have dry mouth. It's also really uncomfortable too, so encouraging your patient, maybe if it's appropriate, you could get an order for ice cubes. If you don't have an order for ice cubes, you can't give them to your patient. We're also going to assess and measure that NG output, not only for color, consistency, amount, but for changes in those things. We're going to assess them for fluid and electrolyte imbalances, nutritional status, and then what are the signs and symptoms that things are getting better and maybe we can pull that NG. So those are listed on the slide there. Let's see. And then let's talk inflammatory bowel disease. Inflammatory bowel disease contains two main diagnoses: Crohn's disease and ulcerative colitis. Crohn's disease is a chronic inflammation of the small intestine, most commonly, and the bowel walls become thickened, and there's shortened, patchy sections that are affected. Usually it's associated with lower right pain, and it's recurrent. It gets better, it gets worse, it gets better, it gets worse. Stools can be fatty and diarrhea-like. It's not common for these to develop fistulas, but anal fistulas can occur. And a fistula is an abnormal tract between two body areas. So two things are connected through a tract that aren't supposed to be connected. Treatments of fistulas are really tricky and complicated and require nutritional monitoring as well as fluid and electrolyte imbalances monitoring. Because you have two tubes that are not supposed to be talking to each other, so the whatever secretions or stool is going in the wrong place. Ulcerative colitis, on the other hand, the intestinal wall is usually thin and inflamed. Larger sections or segments are affected, and this is usually in the large intestine. Most commonly, they report lower left abdominal pain, and the stools are bloody. Lab values that can help us diagnose whether they're having a flare-up is the C-reactive protein. That's more helpful for acute inflammation. It doesn't tell us where the acute inflammation's at, it just tells us whether it's present or not. We use these labs in conjunction with the signs and symptoms evident in the patient. We could also do a SED rate, and that's more indicative or a good marker for chronic inflammation. Again, it doesn't tell us where the chronic inflammation is, but it tells us it's present, and then we can correlate that with the signs and symptoms presented in the patient. So, assessment of inflammatory bowel disease. We've got to get a good health history to identify the onset, duration, and characteristics of their pain, diarrhea, urgency, nausea. Are they having a decreased appetite or anorexia? Have they experienced weight loss, bleeding? Is there a family history of these disease processes? We're going to talk with them about their dietary patterns, alcohol, caffeine, nicotine use. We're going to do a good bowel assessment in their elimination patterns and what their stool looks like. And then a good quality abdominal assessment is important. So what complications are we watching for with these inflammatory bowel diseases? Electrolyte imbalances, cardiac dysrhythmias, gastrointestinal bleeding with fluid loss, and the potential for perforation of the bowel. And I think I've already touched on these quite a bit so far in this presentation, so I won't reiterate them again. Our goals for patients with inflammatory bowel disease are listed here. These are chronic conditions, so patient education and increasing their knowledge of the disease process is very important to make sure that they are adhering to their therapeutic regimen. And then I would say avoidance of complications is huge as well. So we want patients to have a normal elimination pattern. So sometimes we've got to work with them and talk with them and identify their relationships between foods, activities, emotional stressors, and how it affects their elimination pattern. We want these people to have easy, ready-to-go access to either the bathroom or a bedside commode. We want these people to actually be on bed rest because bed rest is going to reduce peristalsis and slow down these disease process and rest the bowels, if you will. And we're going to be really, really diligent in recording every single stool, not only for frequency, consistency, but what did it look like, how much of it was there. We're going to do a good assessment for pain and discomfort. Anticholinergic meds are helpful before meals to, again, slow down the peristalsis. We could give analgesics, pain medicine. We could do optimal positioning, diversional activities, and then providing periods of rest to minimize fatigue. We're going to watch very closely for fluid deficit, so strict I's and O's, daily weights, assessment for symptoms related to dehydration or fluid loss. So low blood pressure, elevated pulse, decreased urine output, dry mucous membranes, all those things are important. Encourage them to eat and drink. And then measures to decrease diarrhea, which I've already discussed. Give them high quality food so that they don't, so the food that they do eat is quality. So what they're getting is good nutrition with every meal. And then a restful environment is really important because remember, stress is going to make these problems worse. Now, colorectal cancer. It's the third most common site of new cancers in the U.S. The big red flags for colon cancer is blood in the stool, symptoms of an obstruction, which would be the tumor, and then the treatment depends on the stage. I've got a slide here that shows you where we can have it and how frequently it occurs in that part. So you can see 30% of it is in the rectum, followed by 25% in the sigmoid. So I would say those are the most prevalent, and then you've got the ascending colon as the third most common. So colon cancers, usually we do a colonoscopy to go in and look, and many times they require a colostomy. And colostomies require some specific care. But not only can colon cancers require a colostomy to be placed, and a colostomy is when they go in and they basically bypass part of the intestine. So